Thank you for being here today. Our session today is the Safespace Home Adaptation, UK-based research and best practice on supporting challenging behaviors, sensory processing, and sleep. Our speaker today is Melissa Talley. Please join me in welcoming her today.
Yeah. Oh, thanks. So Sue King from Safespace was going to be here, but they weren't able to travel. So I am speaking on their behalf. So I am going to read a little bit of the presentation just to make sure that I get their information across appropriately. But I am Melissa Talley. I'm president and clinical educator for Adaptive Imports, and we are the U.S. distributor for Safespaces in the U.S. So let's see. So today we're going to review a lot of the research that's been around for Safespaces. I'm sorry, I have nothing to disclose other than what I just said. So today we're going to go over some information regarding Safespaces. I asked them to put together something about the research that they've done over the last 20 years, because they have some great information that's extremely applicable to the patient population in the US. So we're going to review the challenges that face families, the cost of home modifications, and not just actually the cost of what it is to put it in the home and modify the home, but actually the cost to our the families in society when we don't provide the home modifications. We're going to discuss the challenging behaviors, the sensory processing, and sleep, which I'm sure everyone can appreciate the fact of what lack of sleep does for you this morning, and what we need to do to reduce restrictive interventions, and what needs to be really thought about when we're providing appropriate environments. And then, of course, all of the evidence they have is going to be kind of intertwined within that. So, sorry. So let's talk a little bit about Safespaces. So they are founded 20 years ago, and Safespaces design and manufacture a range of custom-made high-sided beds and sleep areas for homes, schools, facilities, and for respite care. They supply products for people with complex needs, learning disabilities, and physical disabilities who may otherwise not be safe in an ordinary room. So all of their products are custom designed. The Safespace room was in the exhibit hall, so it's designed very specifically for the environment and the child and the family, to be honest, and they are FDA registered. So Safespace's high-sided beds and sleep areas, they fulfill a range of needs. So an example of what they offer is, you can see that they have multiple beds. I talked to some of you about that yesterday or Wednesday. They can be high-sided or low-sided, but actually, I'm going to kind of change that terminology, because in the US, all of them have sides higher than 24 inches. So they're E1399s. They don't fit in the bed codes. They have high-low features and some profiling features, and they can cater to a range of medical care and sensory care needs. So they have a number of benefits. They enable adults and children to stay in the family home, often when that doesn't seem possible. We've had a pretty good eye-opening to this over the last couple of years with the amount of increased institution or psychiatric stays that some of our patients and families have had. They help people access the appropriate medical care that they need, and they enable people to access respite care. The beds are soft, yet durable, and last for many years. They have several clients that have had their beds for 15 years. Okay, so let's talk a little bit about one of the main products that's provided, and that's the Safespace room. That's what you guys saw in the exhibit hall. It's a multi-purpose room, and it's actually classified in the UK as a home adaptation. So it's interesting. That's not anything that we have classification for here in the US particularly, but that's how it is classified there. So here's a brief description of the design and what makes it effective. It's soft, durable, sleep and relaxation space. It's designed for those that would be unsafe in an ordinary room. So there's a lot of repetition to some of the things I'm going to be talking about today. And Sue King said she feels like it's really important to continually to say these things over and over again, so we can really help get a good idea of how this can impact. It's used to support people with the wide range of disorders, sensory processing, poor sleep, and behavioral difficulties. I like to say that it really fits in this moderate to severe behavioral need families, patients and families. It's a space in which someone can sleep, play, and move freely. It reduces the risk of injury by eliminating those hard surfaces. So those hard surfaces is one of the specific things that actually rules this product in when we're looking at various options that are available. Each safe space is custom designed. It's made according to their needs, behaviors, and abilities, and or for individuals that will use it in this and in the space in which it's going to go into. So the home environment or the room it's going to go into is a big part of designing that. When assessing if a safe space is suitable for someone, we particularly need to look at the mobility, the behavior, and the sleep of that individual. In the home, it's a safe bedroom, playroom, or chill out space. It's a low stimulation environment, which can help settle at bedtime and improve sleep patterns. It can also be a high sensory environment when sensory activities take place. So you're able to modulate, help that person modulate for whatever activity they're doing. It's a space to promote independence and privacy. These individuals don't have any really independence or privacy. Someone's either always touching them or having them modify or do different things or even restrict them. And honestly, that actually just makes every situation worse for their sensory issues. And in schools, it's able to support behavioral self-management and crisis management. It can be used as a tool for positive reinforcement and alternative to restrictive interventions. When working with schools, it's recommended that you keep a log so that you can kind of see how when the safe space is used, how the environment affects and impacts in a positive manner, so that you can help to understand and learn the triggers and behaviors of the individual, which actually helps to decrease and de-escalate the amount and the behavioral pattern that's present. It's often used as a therapy space to support a range of sensory needs. And it's often used as a more versatile alternative to a padded room. I'm sure if some of you are here, you've helped families kind of look at that before. And it's worth mentioning, it's funny, I'm going to read this sentence exactly the way it is because it's worth mentioning here that in the USA, many private insurance, state Medicaid, school systems, and waiver systems have funded safe space products. I know what everybody's thinking. It is costly. It's hard to get funded. I have had success getting them funded, appeals, hearings, the first year or so, and then once you get your state representatives and families to be more aware of it, then it actually gets a little bit easier to get them funded. And I like to say that this is a rule-in product. There are other items available for enclosure for these patients and families, but there are some very specific things that these products provide that the other ones do not for that moderate to severe population. So now we're going to explore some modifications and talk about the families that we work with. I understand in the United States that, the funding sources don't really think about the families, or they don't want to know about the families, but if you know this patient population, you know the dynamic of the family and how difficult this is. It's a way of supporting the families of these patients as well. There's a lot of research that's been conducted on the need for home modification and the impact that it has for the family, but also for the society. So it's interesting the take that the UK has approached this and looking at the use of this. And so some of these research things I'm going to talk about are pretty astonishing. We will share some of the research along with some of their own experience findings and data that has been taking place for the last 22 years. So what are the issues that the families are facing, and why do we need to have home modifications? Many of the families we meet have family members that range with disabilities and needs, and that means that they are unsafe in the ordinary room and home, and they require a home modification enabled for them to stay at home. They may display extremely challenging behaviors and self-injurious behaviors that requires a safe relaxation and de-escalation space where no harm can come to themselves, others, or property. They have a limited sense of danger. They can display behaviors such as flight risks, which mean they need to be kept safe. Many children that they meet have physical conditions such as epilepsy. So those who have seizures and require a safe space or the risk of falling and always have to have someone one-on-one with them. They may have irregular sleep patterns and display sensory-seeking behaviors, which cause them harm if they're left in an ordinary room or environment. There's been research by the charity called Scope, and that has shown that the disabled children tend to spend more time in their homes than non-disabled children. And despite this, there is evidence to suggest that their homes are the most restrictive environments in which they spend their time. It's been compounded by the additional pressures over the recent years with COVID, where people have been more isolated and had to have spent more time away from individuals, and we have actually seen the impact of that on the typical population, not just our disabled population. Research from Disabled Children's Partnership that has shown that nearly 3/4 of disabled children have shown regression in their development and also their disability. The whole family has become disproportionately socially isolated and is facing stark medical health problems. So they're seeing the same things we are seeing here and everywhere. So there's research still being conducted following the pandemic, but prior to the pandemic, there was a study by the Disabled Children's Partnership that looked at 2,400 parents and caregivers, and their findings showed that 4% of parents felt that they got the right support and safety care for their disabled child. 37% said their disabled child had missed school or an activity because of the staff services not being available to support them. And if they can't attend that, then more than likely a parent or caregiver also was not able to go to work. So 33% of parents and carers say that their disabled child has been in an unnecessary point of extra pain because of the right equipment not being provided, doctor or healthcare services were not available. So why home adaptations are needed for these families? Living in a home where a person and or a family are unsafe and where access to key areas of restriction have a significant impact upon the well-being of everybody in that household. So what can we do? Modifications have the potential to build resilience, to empower disabled people and those with complex needs to live more independently at home. They significantly can reduce family stress and improve the mental health and well-being of everybody in the household. Appropriate modifications can prevent unnecessary hospital stays. These are families who are in the emergency room multiple times a month. And not only are they receiving care for the emergency need, but they're also being questioned regarding abuse and neglect. And it promotes they can help promote social inclusion and independence of people with long-term disabilities. And the modifications can help deliver some key government and social care policy objectives. So how they're providing services in the UK is very different than in the US, but they've shown some dramatic impact on how providing the appropriate supports can actually positively impact the government and society. So let's talk about the cost of home modifications. I found this information to be extremely eye-opening. Was not surprised by it, but eye-opening. So currently in the UK, people needing home modifications can access a grant. It's called the Disabled Facilities Grant. It ranges from about $1,800 to $36,000, but the average award is about $11,000 for a family. And they get some additional support from local authorities. One important study that they want us to talk about is the Disabled Children and the Cost Effectiveness of Home Modifications and Disabled Facilities Grant, a small pilot study. It was conducted in 2017 by the School of Law at Leeds University and the children's neurological charity Cerebra. It studied the economic and well-being impact of home modifications to accommodate the needs of young people with autism spectrum disorders who had behaviors that challenge. It's a phrase that they use, but it's challenging behaviors. The research was conducted with 6 families. All had applied for home modifications from the same local authority. The research took place through observations, interviews, and case studies. It was a small but extremely important study. The adaptations averaged 73,000, were designed to provide safe spaces for the young person. This included the creation of safe garden areas, so safe outdoor activity spaces, padded walls, new doors, shatterproof windows, as well as a specialized bedroom and bathroom furniture, and each family got a safe space room. In all cases, the individual's behavior involved serious harm to themselves, the property, or others, and they all required constant supervision, and 5 out of 6 said that they didn't really see any other option in the future other than to put their loved one in a facility. So they were all looking at long-term care. So the well-being findings of the study were that the most commonly mentioned well-being benefit to the young person was that he or she had space to relax and be safe. For parents, it was that they felt less pressure and they were healthier. Significant benefits were identified for the siblings, who now felt that they were able to have a safe space and privacy and independence and actually have friends over. The economic findings, while the cost of the economic adaptations were met by housing budgets, the savings that was made benefited the health and social care budgets, and it found that the cost savings for a younger person's grant are likely to be higher as the benefits spread over the period of time. So what they saw was the financial impact was an investment in housing modifications of $370,000. It avoided social service costs of $1.8 million. Those 6 patients saved $1.8 million. The principal cost was that the modification had avoided the need for the young people to be taken into a residential facility, and it kept families together. The evidence of the families in these cases was that modifications avoided a total of 11 years of, they call it looked after funding. So they have this wonderful program where it's basically a respite care. So if you were in the other talk yesterday, Christine talked about having a couple of the individuals come and stay with her. So they have these programs where kids can go and get respite care for a weekend out of the month or a week out of the year, or every month they spend a week or a weekend with the family. And if they don't provide those services, they know what's the negative impact. And a lot of those kids go into full care facilities. So because they were able to do that, they were able to sustain the caring role for their loved one for a total of 3 to 7 years. So they kind of looked at the families and the ages of the children and said, so overall it was a total of 15 years of looked after child status was avoided. So that's where you get that $1.8 million, as they're looking at the long term. So you're able to access, the references are in the back, so that study is there if you want to read that in more detail or cite it in a letter or two of recommendation. So the challenging behaviors, right? So we all know the impact of the challenging behaviors. We see that. It's described as challenging when it's such an intensity, frequency, or duration as it threatens the quality of life or physical safety of the individual or the other and others around them. And it's likely to lead to responses that are restrictive, aversive, and a result of exclusion. So if you know these families, you know that is completely a true statement, and these families really struggle. It may include causing harm to themselves or others, destructive behaviors, eating inedible objects, flight risks, smearing, climbing, running, hiding, and repetitive behaviors, and spitting and screaming and even urinating. We've all seen individuals do this. This term describes the behavior as challenging to services rather than the problem being with the person. It encourages carers and professionals to find effective ways of understanding the person's behavior and understanding the causes. They're acting out, and these things are a result of something going on. So for people with autism or learning disabilities, it can be difficult in the world designed for neurotypical people and may cause them distress because of underlying sensory needs. The challenging behaviors that are displayed have reasons or a function that's important for us to focus on the underlying reasons rather than the behavior. They may be acting out as a way to control what's going on around them and get their needs met. It may be to communicate high levels of pain and distress. And it's a means of avoiding things that they don't like to do or a way to meet their sensory needs. As the Challenging Behavior Foundation states, the earlier challenging behaviors can be understood and strategies are put in place to help reduce behaviors, the better it is for the person and those caring for them. So I've done a lot of sensory integration and modulation therapy, and I know it's not something that's necessarily funded anymore as treatment, but we all know as clinicians in the room how impactful it can be to ready someone for therapy or ready someone for an activity or just ready someone for any kind of intervention or activity or participation, and just prep to make sure that it's a successful event. Sensory integration and processing difficulties occur when the brain has trouble interpreting and reacting to incoming sensory information for the body and the environment. According to the National Autistic Society report in 2021, it is estimated that between 5 and 16.5% of the general population have symptoms associated with sensory integration difficulties. And these estimates are higher for people with autism and ADHD. So all of us in this room have some form of general sensory integration difficulties that we kind of have learned how to manage on our own. An unsafe and unsuitable environment can have a direct impact on those behaviors, and it's crucial that the home environment is suitable to meet those needs. The safe space is often prescribed for the home modification for these individuals, and a couple different areas are what we look at. So it can be used as a retreat. So the homes can be highly stimulating environments, and it's often difficult to identify the triggers when someone's upset and when they're hypersensitive, or someone who's hypersensitive. The person may be overstimulated by certain noise and lights. They're unable to communicate their feelings, and they struggle to concentrate, so they show frustration. And allowing an individual to take themselves to or indicate that they want to go to a safe space gives them the opportunity to learn and manage their reactions and their stimulation. A sensory diet. The safe space is ideal for delivering a sensory diet because it's adjusted to create a low or a high environment very quickly. It's crucial for an individual's sensory needs that may fluctuate throughout the day. And most sensory equipment can be utilized in the safe space. Lights, tactile objects, parents and carers can use the safe space to offer interaction, massage, and other therapeutic activities to support the individuals and their processing needs. For those who have vestibular imbalance difficulties, it's got the foam floor and the vinyl sides that are able to sustain impact with less harm, and actually help them to maybe overcome some balance, vestibular, or even fear of movement. Proprioceptive feedback. The flexible walls of the safe space work well for this. They're able to rock, and if someone who would rock violently against a wall or are able to do that in the safe space safely, get the appropriate feedback but not be injured. So they conducted a survey for people that have safe spaces installed in their homes, and the most recent results showed that 32% of families see an improvement in sensory issues. So, and by that they mean that the need for de-escalation was less, the behavior patterns that came out were less, and what they were really seeing is they were using it as a functional position, not just for the need for de-escalation or breaks. So what constitutes a safe, suitable environment? They know that the safe space works, and now they have proof. Foundations is a national body for home improvement agencies in the UK. They are contracted by the Ministry of Housing, Communities, and local government to oversee the national network of nearly 200 home improvement agencies across the country. In 2021, they conducted a research study called A Guide for Children and Young People with Behaviors That Challenge. The guide is based on a range of key legislation. It draws on key research, and it uses its own data collected from the health and educational professionals, parents, carers, families, and key stakeholders. So a lot of this information here I'm going to talk through are things that would be important for us to include in our letters of recommendation. It provides case studies and examples of good practice in order to support the effective use of modification grants. In our case, it would be to try to get funding for the products. It provides recommendations for the design of adaptations for the children and young people that challenge. So these beds, like I said, are very individualized. You can choose colors, different supports, just different viewing panels that are needed. And Amy at Adaptive Imports is very comfortable with all of this. So if you have families that are looking at this and you're like, I know what bed I want, or I think I know what I want, Amy's able to help walk through those. She's got a series of questions that she'll ask to kind of help with that process. So the space is recommended to have control not just our safe space bed, but anything you're looking at to modulate for these individuals, whether it's one of the other options as well. You want to look at a controlled acoustics to minimize background noise and to dull the sound of repetitive behaviors such as headbanging. You want appropriate lighting that can be adjusted to provide calm, relaxing environment. The lighting should be difficult for the individual to access. Designing the safe spaces can support routine and predictability with minimal distraction. It's ensuring the space has clear functions and sensory qualities that help define its use. It's not something that you're locking someone in. It's got a very strict functional medical need and use. Providing an escape space from the overstimulation of other environments. A safe space or a crawl space in a quiet environment should be neutral and customizable. Transitions transition zones that help with an individual calibrate their senses as they move from one activity to a next. Safety is key for someone who may have an altered sense of the environment. So safety features may include the avoidance of hard and sharp edges and corners. And the space should promote inclusivity. They should be non-institutional design with consideration for color schemes, patterns, textures, finishes, and themes should create a homely space that doesn't overstimulate and can provide differentiation between space if required. And thankfully, their safe space provides that. So they have a couple stories that they're wanted to share. So this is Thomas, and you can go to the link that's on the slide here to see the actual video. But Thomas lived with his mom and his older sister in their family home. Throughout his childhood, he experienced difficulty sleeping as he entered puberty. This became more problematic. If you know this patient population, as soon as puberty hits, everything goes way south. At the age of 13, he has autism. He began to express increased anxiety and presented extremely challenging behaviors. Included self-injurious behaviors, such as banging on hard surfaces with his hands, and it meant he was no longer safe in an ordinary room. Thomas was prescribed melatonin to help him settle at night, and his family tried a range of techniques to help him, but nothing really helped. Thomas and his family were all suffering from sleep deprivation, and there was an increased risk of self-harm as Thomas entered into his teen years. After looking at a range of options, a safe-space multi-purpose room was recommended for Thomas. It was because it would help to reduce the risk of injury and promote good sleep hygiene and provide a safe, calming, low sensory environment. The flexible size of the safe-space meant that Thomas would be safe from hard surfaces and provided a safe nighttime solution. Following the installation of the safe space, Thomas's sleep patterns significantly improved as he felt much more relaxed and was able to focus on going to sleep without any distractions. During the day, he was also able to use the safe space to de-escalate and self-calm if he felt overwhelmed. The safe space helped both Thomas and his family to effectively manage challenging behaviors and improve the quality of life for the whole family. It also gave Thomas more independence as he transitioned into adulthood, and after 9 years, he no longer needed the bed and they donated it to another family. Another story is a family with autistic twins. Peter and Paul were nonverbal and presented with behaviors that challenged, including aggressive tendencies towards each other, anxiety, and inability to cope with sensory overstimulation. The primary caregiver was mom. She was a single parent, and there were 2 other children that also lived in the home, and everyone was suffering from extreme sleep deprivation, and this family was at serious risk of breakdown. Following the provision of the safe space, the twins developed better sleep patterns, their aggressive tendencies were reduced, and their sensory anxieties were able to be effectively managed. Social care was able to reduce the costly specialist childminder, so they didn't require to go visit their families in that respite care. So there was a huge impact on the cost to the community. And the mother and siblings experienced a significantly improved quality of life. So basically, the safe space basically saved this family. Challenging behavior can lead to restrictive interventions, which are hugely detrimental, can escalate to severity of the problem. So there are a lot of people that actually see these enclosure beds as restrictive, but it's actually quite the opposite of that. So what are restrictive interventions practices and why are they so serious? There's many examples of restrictive practices used in everyday life. These include environmental, physical, chemical, mechanical, psychological, such as withdrawal, seclusion, and segregation. Results by the Challenging Behavior Foundation found that 88% of families reported that their child had experienced a physical restraint, and 35% reported that it happened regularly. The restraints are traumatic for everyone involved and can have long-term negative effects on someone's physical, emotional, psychological health, and really that's everyone, the parent, the child, anyone else who's involved. In 2019, the UK government launched its recommendation strategy called Reducing the Need for Restraint and Restrictive Intervention. It highlights that using positive behavior support and other alternatives which can de-escalate challenging behavior and tackles the reasons for its source should be the preferred approach. Again, this is an extremely important study, I think, for us to cite and be aware of in the US when we're making these recommendations. The report provides advice and recommendation, which is used to support relevant education, health, and care settings. So it's recommended that we read the whole report, which I highly advise you to do as well. But to give a little bit of an idea, it recommends that it's vital that work is undertaken to understand the needs of the child and the triggers. Strategies and plans should be developed to meet the needs of the child and the young patient. We should be proactive, not reactive. A lot of our intervention or gut reactions to these outbursts is reactive, not proactive. Adapt the environment that the children are taught and cared for in to meet those needs. Provide appropriate support without the use of restrictive intervention. Provide a consistent approach to behavioral management. Consistently record and review the incidents and map patterns so you can try to figure out what the triggers are to help modulate the situation and long-term effects. And use evidence-based approaches for behavioral support. It can be considered the least restrictive practice when used as an alternative to the types of interventions and can reduce the risk of injury to individuals and those around them. Sleep. So we all know that these patients have significant sleep problems. It's actually one of the most common challenges is that we hear from parents and caregivers. Sleep disorders have profound effects on individuals and their families. Poor sleep can result in poor mood, irritability, and impaired concentration. In children, sleep is important for growth, with some stages of the sleep cycle actually releasing hormones. Poor sleep has also been attributed to lowering the immune system. And the recommendation from the Sleep Charity are that children need more sleep than we think. 1 to 2-year-olds need 11 to 14 hours, including naps. It reduces slowly until they reach the age of 13 to 18-year-olds who are recommended 8 to 10. My 15-year-old sleeps all the time, so I don't believe that. But, but 13, 18, we definitely see those patterns change. Yet according to SCOPE, the Disability Equality Charity, in the general population, 3 out of 10 children have sleep problems. But it's 8 out of 10 children for those with intellectual disabilities. Sleep issues can be for a range of reasons. Physical health conditions, genetic conditions, incontinence, pain, seizures, psychiatric vulnerabilities, fear of the dark, medication effects, differences in internal body clock changes in the release of the sleep hormones. We see this a lot with this patient population, especially like Rett syndrome. Their sleep cycles are off. They're awake when everyone else is asleep. Differences in sensory processing, distraction, confusion, distress, and parental response to the child waking. So learned responses. They're crying, we go in. It starts to get into a pattern. And then of course, hospitalization. If you have patient populations that are in hospital, you can see how that greatly impacts sleep for the whole family. The bigger picture is that sleep deprivation is a huge issue for the whole family, according to a report in the Sleep Charity in 2020. So the UK is spending an average of $60 million to help the UK get a good night's sleep. $60 million. 21% of doctors' consultations in the UK are related to sleep. 3/4 of the depressed patients have sleep-deprived related problems, and sleep deprivation is common amongst people with suicidal thoughts. Sleep deprivation amounts for a massive $48 billion to the UK workforce in loss of productivity. It's estimated that that's going to rise by about $7 billion by 2030. Sleep Charity advises that 20% of road deaths are related to sleep deprivation. It's estimated that if individuals slept 6 hours, if they could sleep 6 to 7 hours, this could add $35.9 billion to the UK economy. Sleep deprivation. How the safe space meets these needs, right? So providing a safe space to the family, it greatly improves the lives of families. We've said that repeatedly here. It supports the families to follow the advice of the Sleep Charity and other organizations mentioned in this presentation, and have seen that the safe space supports these in this way. The safe space provides low stimulation, quiet environment where visual distractions and noises are removed, and they're dampened by the flexible vinyl walls. It can help settling at bedtime, getting into more bedtime routines, and get in that ready state. It can provide a safer environment for those who continue to wake through the night. And so if a child's up at night, somebody else is up with them. If they're in a safe environment and they're able to know what's going on, everybody else can sleep because they know that that child's kind of in that bed and they're in a safe environment, can reach and call out if needed, but everybody else is able to sleep. Parents are able to monitor their children's sleep patterns easily, and we recommend the use of a sleep diary so you can figure out triggers. A safe space provides separate, calm space in which parents can develop a positively associated sleep routine and also a relationship with their child. Over time, users can begin to recognize their emotions and change in their body and start to understand their own behaviors by taking themselves or requesting to go to the safe space. Again, if you've provided any safe environments in schools or homes, and kind of work through those options, those patients catch on really quick with either picture symbols or requesting that they need a break and they need to go somewhere. The safe space provides an ideal space where someone who needs high-level supervision can spend time being on their own, but observe from a distance, promoting inclusivity, giving them privacy, and that they need to de-escalate and act out for their challenging behaviors. It's a form of retreat where routine and predictability can be established and where a safe transition zone can be created. So they did some of their own in the last year. They did a survey of families, and they received some qualitative feedback. They received that daily, and they recently launched this client survey. And most of the results are from parents, but some of them are from facilities, care providers, or therapists. It showed that 93% of the people reported an increase in safety. 76 reported an improvement in family life. 62 report improved sleep patterns. 51 improvement in behavior. 40% report improvement in independence and privacy, which is a fundamental human right. 32% report improved sensory issues, and 7% report a decrease in the need for medication, which is not a big number, but it is important to note because I think it's something that we definitely need to look at. To summarize, Safespace believes it's crucial to understand the needs and behaviors of children with complex needs and disabilities. They have seen that effective and creative use of home moderation budgets can make a significant impact on the lives of people with autism or learning disabilities, as well as on the lives of their families and carers. Such an approach can also make sense financially. By helping to avoid unnecessary admissions to residential cares, appropriate use of modification budgets not only deliver better outcomes for people with autism and learning disabilities and their families, but can also at the same time deliver better value money for our local authorities. One weekend stay at College Hill and Cincinnati Children's would buy 3 of the safe space beds. So, I mean, just thinking through those processes and the amount of money and resources at the emergency room and lost work time by the families or caregivers. They work with ATPs and professionals and families to design the products based on the key guidance of good practice discussed today. So, and that's really goes into what we're doing here. So we all know how the ADAPT equipment works, but a lot of times in the US, these families don't know how to get to us. Physicians don't know that it even exists. So I think in the school system, sometimes they don't even know that it exists. So I think it's important. That's why I asked them to pull this research together so that we can get the information out here. It's got very good sound data for all of us to use in our letters or recommendation, honestly, for any bed that we're recommending. And it gives us an opportunity to do some additional continuing education down the road to kind of get to the physicians, get to the clinics, get to the schools, get to the families so that they know what's out there and available. Are there any questions? Yes.
Did they create any sort of protocol to introduce and implement this with a family? Just thinking of students who right now are like locked in their bedroom, in their room, and now all of a sudden we put the safe space in their room and we're trying to introduce it to them.
Yeah.
Is there any sort of creative protocol around that?
Not that I know of from them, but I think I would go utilize all of the information they had here and the different, like the low acoustics and educating the family on that. A lot of times in the evaluations that we have done is when you're asking the families these questions, do they ever try to exit the home at night? Have they ever tried to, these kids are on top of refrigerators. One of my patients, a 6-year-old, climbed to bed with his 1-year-old brother because he just wanted to cuddle. And mom said if she didn't have the video monitor on, he would have killed the 1-year-old. He would have smothered the 1-year-old. So I think there's just, they've started fires, they do it. So if you ask those questions, they're doing it. Usually when I start to explain what the beds will do, and the ruling in and ruling out, they're relieved. Like, they don't want to lock their kid in their bedroom, right? They don't want to know, they don't know what the resources are. Physicians have offered things to help and it doesn't work. So it's just, they just stop asking. And a lot of times how we tended to get to this patient population for the moderate to severe is they were being referred for a car seat for elopement, or they were being referred for an adaptive mobility because of elopement. And it's really the trifecta. So you start asking the other questions, and all of them who were referred for that ended up getting the trifecta of something. They needed a bed, they needed a wheelchair, and they needed a car seat. So I think it's unfortunate that they don't have access to this, and it's unfortunate that the care providers and the nurse care professionals and everyone don't know that these products are available. A lot of them don't even know, like, they don't even know the Haven bed's available. They don't know any of it's available. And physicians will even say, you know, I recommend a Posey bed. You can't get a Posey bed now. You know, and unfortunately, I've heard from a few people this weekend that some of the deniers will come in saying that you can lock them in their room. You don't need a bed because you can lock them in your room. You can't lock them in their room. I don't know what, I mean, you need to go back and appeal those. So it does take a lot of energy to do that, and it does take time with the family, but once it gets set up, if you go through with the family, like some opportunities to do it, they're going to use it the same way they're using that locked bedroom, but they're going to see progress right away because, you know, it just really works really well. I mean, these kiddos, they want it. And when you provide it, they learn how to modulate themselves if you provide the right resources. So. Yeah, go ahead.
So if that customized, then it's ideally that child is going to be like, yes, I want to be in there. And there isn't, you don't really have to train so much on how to get in there.
Exactly. Yeah. And those families know some of those triggers. They're just reacting to the triggers instead of proactively. So a lot of these families don't even know how to proactively provide deep pressure and give routines and be very consistent. You know, the families that do this well, the entire schedule of that family moves around that child. And if things need to happen around them, they get that child trained on that routine. So when COVID hit and they didn't get to get picked up by the bus, they didn't get to go to school, they didn't get to come home, they were just home, it was a disaster because their routine was completely dumped upside down. And a lot of these families very quickly had to resort to inpatient stays. The inpatient stays at Cincinnati Children's were ridiculous, and they still really have not come down for various reasons. And they're starting to have some additional impacts. Like they're starting to get up and like pull the ceiling panels down. Like there's a lot of things going on. So they're looking at their environment, and you know, having a safe space or something in the College Hill environment would be great. So I think it's not just homes, it really is schools and facilities. And everybody sees the dollar sign and freaks out. But nobody freaks out about a $30,000 permobile. You know, I mean, these kiddos don't need that, but they need this. So, and it takes time. I think we're to the point where we're really like at an early stage of this. It's going to take a lot of time. It's going to require an appeal. It's going to require a fair hearing. You're probably going to get told no. A family in Alaska was told they can put him in a playpen. He's 9. A playpen. He's 9. It's not even appropriate for the size and weight at all. So they did not win their fair hearing, but the mom, it had been a year since they did the eval, so she went back and did the evaluation, and they're getting ready to submit it all over again. She's going to do that hearing 15 times if she needs to, while she tries to figure out resources for the bed. So I think it's, you know, as those things happen, my team from the Perlman Center, we worked really hard on different letters of medical necessity. So at Adaptive Imports, I have a sample letter of medical necessity for the Dreama sleep system, the Safespace bed, and the Siesta bed, which are 2 of the Safespace products, with a very significant roll in, roll out. Mattress on the floor, bed with side rails, twin bed, locked door, and then talking about what they really need, and then ruling out the adapted beds of the Sleep Safe and the Beds by George. And then you move into the enclosure beds, and you just have to go through each of those beds and talk about it. So, you know, prior to where I'm standing now, I utilized that letter to recommend a Haven bed and roll out the others, recommend an Abrams bed and roll out the others. And so what I've done with that letter is it fully recommends all the things that you would think about and consider for that moderate to severe patient who needs the sleep safe. It's the ruled in opportunity, but or safe space, I'm sorry, safe space. So you can use that letter for any of those options, but it just lays it out. And then it gives clear definition clinically and medically and behaviorally. So when they appeal, you just go back and you answer their questions, provide additional research. And then when they go to the fair hearing, the family has all of that information that you can coach, or I can coach them on how to speak on behalf of their child and what their child needs are and what not to say. So not to say that I can't go to work. They don't really care about that, right? So everything needs to be in the line of the patient, but there's definitely ways that you can change that terminology around when you're answering those questions and submitting. And if there's any availability at all virtually for that child to be in the background when they're doing that fair hearing, and to give a little bit of a picture, or even take a video, have the families take pictures. It's going to take a lot of work, but it's definitely a necessity. We did this for permobiles a million years ago too. So we had to do all of that for the high cost product.